Okay, thank you. I'd like to thank the organizing committee for the opportunity to present this data on behalf of the DAD study group. So just to give you the bit of a background about the topic, ART initiation is often associated with weight gain, often even in those people who are not necessarily underweight at the time of starting ART. So this has been shown in a few cohorts now, including 1917 cohort, Swiss cohorts, and others. So there is one example here from 1917 cohort, 1917 cohort on the right. And there what you see is that over the one year of ART initiation, the proportion of people with being obese or overweight actually substantially increased, and in this cohort this appeared to be sustained over time. So the weight gain on ART initiation has often been thought to be a good prognostic indicator if you traditionally see in terms of AIDS outcomes especially. But its impact on cardiovascular health, especially in people who are not necessarily underweight at the time of starting treatment, is unknown. So there was one analysis from the VA cohort presented some time ago at CROI that basically showed that per 5-pound gain on ART initiation in weight is associated with about 10% more risk of incident diabetes. So we thought it's a better understanding of this relationship between weight change at ART initiation and the serious events is required. So the objective was to assess the relationship between short-term change in BMI after first ART initiation and the subsequent risk of our two key outcomes. They were cardiovascular disease or CVD and diabetes. So we used the data from the DAD cohort. The DAD cohort, you would know, is a large cohort consortia having several thousands of patients. So this slide, if you walk from left to right, essentially shows you the way we went about selecting our patients. So the patients had to enter the DAD cohort, and they had to be ART naive at the time of entry, and then subsequently starting ART. They had to have the BMI at the time of ART initiation as well as 1 year after ART initiation, and they should not have had the event of interest, in this case CVD, before the 1 year time point of ART initiation. So our analysis time was from the time 1 year after ART initiation to the time they had event or they got censored. And we ended up with about 9,400 individuals. And the key variable of interest was the absolute change in BMI at 1 year time point after ART initiation. So I won't go into the full details about how we defined the outcomes, but essentially the CVD was a composite outcome of MI, myocardial infarction, sudden cardiac death, or invasive vascular procedure, or a confirmed stroke. So in DAD study, the details are on the website listed there, but in the DAD study, this is these outcomes are validated in real time by a very clear predefined protocol. And similarly for the diabetes, there's a DAD definition, which we can see the details on the website. But of note, these outcomes are validated in real time in the DAD study. All right, so statistical methods. So BMI change, which was our variable of interest, was essentially modeled as a continuous variable after our initial exploration about the event rates. And I would present some analysis about this variable change in BMI. So then we went about modeling the relationship between the change in BMI and the outcome of interest, CVD or diabetes, using Poisson regression analyses. So for each of the outcomes, we adjusted for the key risk factors which have been previously identified in the DAD analyses. So for example, for the CVD outcome, you know that there's a DAD risk equation, so we essentially used all of those variables. Of note, that included the variables related to the treatment. And similarly, for the diabetes, we adjusted for the relevant risk factors. The key references are listed there at the bottom. So models were sequentially adjusted for the key variables, and I will go about in more details a bit later. So if you concentrate on the last point, we assessed if the pre-ART BMI is an effect modifier. So we wanted to allow for the possibility that a gain in weight may not mean the same depending on what is the starting weight. So people who are underweight, for example, might benefit differently than, say, who is normal weight from the weight gain. So we allowed for that possibility using effect modification. So some results. So this is the evolution of BMI change post ART initiation, and as it has been shown in previous cohorts, other cohorts. What you see is that in the first year after ART initiation, there was a sharp spike in BMI, especially in people who were underweight, but also substantial in those who were normal weight. The definition of those categories is on the right. And people who were at the extreme, so the overweight or obese, didn't seem to gain as much or had a flattened curve. But people who are underweight or normal weight essentially gain weight for the first year, and then they actually seem to sustain that weight gain over the period of time. So our variable of interest was essentially that spike in the first year. So these are some patient characteristics at the time of ART initiation. So of note, a majority of the patients we had were in the middle two categories, the normal and the overweight, and only about 6% of patients in the extreme categories. So the point to take home here is that this was a very low risk cohort as compared to the DAD population, and of note, the smoking seemed to be actually inversely correlated to the BMI, which is I guess expected. All right, so for the CVD outcome, we had about 100 events at the rate of about 2.2 events per 1,000 person years. So the rates are listed there by the BMI category at the time of starting ART, and as you can see, there was a trend of increasing rates of CVD by the increasing pre-ART BMI. So I will try to explain this. This is a slightly tricky graph, but essentially this is what is showing is effect modification by pre-ART BMI. So the plots that you see are adjusted incidence rate ratios for CVD outcome per unit gain in BMI. And what you see there is that the unit gain in BMI did not mean similarly across the categories of pre-ART BMI. So the people who seemed to actually elevate their risk by gaining more BMI were the ones who were normal weight at the time of starting ART. And then this was independent of how we adjusted our models. I won't have time to go into details, but essentially we did have models which accounted for all the variables in a time-updated fashion. The underweight people on the extreme left seem to actually gain some benefit from gaining weight, gaining BMI, but the confidence intervals were wide. And also on the extreme categories of overweight and obese people, the risk did not seem to elevate much after gaining weight, and I will detail upon that a bit later. So this is just categorizing the pre-ART BMI in an alternative fashion as a pre-ART quartiles, just to make the distribution a bit more even. And what you see again is that in the middle two categories were the people who actually had the elevation in the risk of CVD by gaining BMI to about 20% more risk. People at the extreme, so people who are in the first quartile on the far left were actually seemed to be benefited from weight gain, but that confidence intervals were wide. And in the last quartile, they didn't seem to change the risk much. So now on the diabetes outcome. So we had a very similar inclusion criteria, so I won't repeat that. We ended up with the very similar cohort, about 125 events at the rate of about 2.9 per 1,000 person years. The rates by pre-ART BMI are also listed there. As you can see, the BMI rates, the diabetes rates sharply increased with increasing BMI, increasing pre-ART BMI. So if you concentrate just on the far left, for the diabetes outcome, there wasn't much appreciable effect modification by the pre-ART BMI. So in other words, for all patients, regardless of the pre-ART BMI, the gain in BMI, per unit gain in BMI was associated with about 11% more risk of diabetes. And this was also independent of how we adjusted our variables right there. But just for consistency's sake, if you spread it out by the pre-ART BMI, you would see that most people had the elevation in the risk of their elevation in the risk of the diabetes, regardless of their pre-ART BMI, if they gain more BMI. So the p-value for the effect modification in this case was not significant. So we did several sensitivity analysis. So of note, for the CVD outcome especially, we did exclude injecting drug users. So because injecting drug users tend to be a special population in that they tend to have a lower BMI, but also they tend to be at a risk of secondary CVD events, non-atherosclerotic CVD events. So excluding them did appear to make the results, in fact, more significant. The IRRs actually were slightly higher for the CVD outcome. For the diabetes outcome, it was similar. And other sensitivity analysis also results were quite robust too. So we had, I think we had several strengths, including the fact that it was a heterogeneous population. We had many potential key confounders, the modern cohort, but I think the limitations were that it ended up being a bit selective sample, and BMI may not be a perfect marker of the central obesity. We didn't have several other key variables which could have been useful. So I think to conclude, we think short-term gain in BMI post-ART initiation could be associated with the increased risk of CVD, largely in those with normal to mid levels of pre-ART BMI, but this would need verification in other studies. Consistent with previous studies, BMI gain was associated with the elevation and risk of diabetes. There wasn't an appreciable change in risk for people who were gaining BMI and they were at the higher end of the pre-ART BMI, which could be simply because possibly we had lower power, but also because we did exclude the people who had event before. So we probably excluded the people who were at high risk. But so this finding, I think, should be interpreted cautiously. So I think our goal was to get the message that weight gain after ART initiation may not necessarily be a good prognostic marker, and that weight management issues in this population require further attention. So it's the acknowledgements. Thank you so much.